In order to identify suboptimal response to TKI therapies in these days, we really follow the NCCN guidelines that they are really a very specific recommendation about the milestone that patients need to achieve at certain times to be able to really have a very good outcomes at the end. So 3 months, 6 months, 12 months, patients need to be in a specific PCR levels of cytogenetic levels, and at this point, still there is some patient, although there is not many, but definitely there is a proportion of patients that still cannot really achieve these milestone outcomes, for which we do recommend to switch therapies. Most of the times, we recommend to switch TKIs to another TKI, sometimes from first generation to second generation TKI, but of course we have many of them. However, because sometimes patients are resistant to multiple of these TKI or even intolerant, that maybe is more frequent that resistant, we have to really try to really find non-TKI therapies that can really solve this problem with these patients.
The patient characteristics that prompt a switch in tyrosine kinase inhibitors or TKIs are many and predictable by the choice of the tyrosine kinase inhibitor used. For example, imatinib mesylate, which was the first TKI to be tested in CML, was found to be very effective, but its main side effect was edema and some GI toxicity, which in rare cases causes abnormal liver function test and some diarrhea, which led patients to switch. Later on, nilotinib was tested as a second-generation TKI along with dasatinib, the latter being a SRC inhibitor, and their spectrum of complications or intolerance is different. With nilotinib, it's pancreatitis, liver function abnormalities, and worsening of diabetes, whereas with dasatinib, a SRC inhibitor, and later on, bosutinib, a narrower SRC inhibitor, the side effects were fluid accumulation, especially pleural effusion. Later observations have also found that there are late complications, such as cardiovascular complications with certain TKIs, and some of these include arterial thrombosis in the case of nilotinib and pulmonary hypertension and other events with dasatinib. And the last TKI that I did not mention was ponatinib, has the greatest side effect on the cardiovascular side. Most TKIs are associated also with hypertension. So again, you have to individualize each case when you decide to switch. In my experience, patients late tend to switch also if they are dark-skinned and they find lightening of their skin, because the c-KIT inhibitor TKIs that include imatinib, bosutinib, and nilotinib are able to inhibit c-KIT and inhibit melanocyte production in the skin.